Kinesiology 461 Project. Stingers and Burners.
Are you okay?
I'm fine. I just have tingling and numbness going down one arm. I'm just gonna keep playing though.
Are you sure that's a good idea?
That's probably fine.
All right.
I've got one stinger in one arm. I hope I don't get another one in the other arm now. Ah, I can't feel either of my arms. The situation. A rugby player sustains a stinger during a tackle. What is the evaluation and the return to play criteria for this athlete? And now for a quick quiz before we start the lecture. Learning objectives. The student should be able to list the major distinguishing symptoms of a stinger and the red flags associated with more serious cervical injuries, list the common mechanisms of injury, outline and perform the proper evaluation procedure for an injured athlete on and off the field, describe the return to play guidelines for stingers, both acute and recurrent. Stingers are a unilateral peripheral nerve injury occurring at a point from the cervical nerve root to the brachial plexus, resulting in a burning type pain in the neck or upper extremities and is frequently accompanied by paresthesia and/or weakness. Stingers and burners are most commonly reported in collision sports. It is beneficial to note that the symptoms, mechanisms of injury, and return to play protocol is similar between rugby and football due to the contact nature of the sports. Up to 65% of college football players have reported suffering at least one stinger. 45% of athletes with a previous history of a stinger would have recurrent episodes. Now, how many athletes do you think actually report getting stingers? A study published in the BJSM focused on Premiership Rugby Union players. 95% of players who suffered from a stinger carried on playing without treatment or even leaving the field. Since these players left their stingers untreated, do you think there would be health implications associated with this minor injury? Symptoms associated with first-time stingers resolve fairly quickly. However, neurological deficits, especially motor deficits, can occur. The chances of these deficits occurring and lasting longer are higher with recurrent stingers. A greater risk of secondary musculoskeletal injury can also occur as a result of motor deficits. For example, a rotator cuff tear due to C5 or C6 radiculopathy with weakness. The chance of having a recurrent stinger increases after having an initial stinger. A study done by Levitz, Riley, and Torg found that 87% of people with recurrent stingers had evidence of disc disease in the form of a disc bulge, disc protrusion, or frank disc herniation deforming the cord. It was also seen that 93% had narrowing of the intervertebral foramina secondary to degenerative disc disease. Proper and timely treatment for stingers is crucial in preventing recurrent stingers from happening and preventing the development of disc diseases and nerve compression syndromes. Some symptoms include burning type of pain in the neck or upper extremities, paresthesia and/or weakness in the arm, key feature being the unilateral symptoms. The athlete exits the playing field unaided, often with the affected limb motionless against the abdomen in a sling-like position. First occurrence stingers symptoms usually resolve quickly, often within seconds to minutes. Red flags for the injury include burning in the hands, which signifies a much more serious central cord injury. A bilateral burning type pain in the neck or upper extremities indicates a much more serious spinal cord injury, being transient quadriplegia. Mechanisms of injury include nerve root compression in the neural foramen, extension and compression. This is the most prevalent method of injury as determined by multiple studies. The next most common mechanism is a brachial plexus stretch, a traction injury. And finally, a direct blow to the nerve root plexus. These injuries occur as a result of a direct blow causing depression of the shoulder and the neck is forced into a lateral flexion which causes the neck to bend the opposite way. Here is an illustration of the cervical nerve root compression mechanism. This is an illustration of the stretching of the brachial plexus mechanism. The initial on-field protocol: be alert after a collision for players holding their arms in a sling-like position. If you suspect a burner has occurred or a player comes off the field complaining of burner-like symptoms, you should follow these guidelines. Distinguish the injury between a peripheral nerve injury and an injury to the CNS. Check for red flags that signify a more serious spinal cord injury. Immediately start a full-scale C-spine rescue protocol with any red flags. Determine the medical history of the athlete and how the injury occurred. Perform a thorough examination of the cervical spine. Palpate all structures for points of tenderness, swelling, or deformity. Ask the athlete to actively rotate, laterally bend, forward flex, and extend the neck. Functional muscle tests done on affected areas. Muscle weakness is commonly found in the deltoid, biceps, supraspinatus, and infraspinatus. Perform the following examinations: Sperling type maneuver to assess nerve root pain. In a study done by Livitz, Riley, and Torg, Sperling maneuver was positive in 70% of patients with burners. In the Tinel sign, brachial plexus test, positive result signifies neurological irritation.
So today we're going to show you how to do this Sperling maneuver. So what you do, you want to have your athlete in a seated position and have your hands like this interlocked, and you want to put a compressive force straight down, and you want to laterally flex their neck towards the effective side. This is considered positive if he experiences weakness, numbness, or tingling radiating down the effective side. So next we're going to show you how to do the Tinel sign for brachial plexus test. We want to have the athlete in a seated position. You want to first slightly laterally flex his neck and tap along the brachial plexus along the nerve trunks. This is considered positive if he gets a tingling sensation along those nerves.
Ancillary testing is typically only used in burners that have prolonged or recurring symptoms. Imaging the cervical spine and shoulder girdle to assess pathoanatomy has been shown to have limited value. Electrodiagnosis of the cervical nerve roots and brachial plexus to assess neural dysfunction can be useful, particularly with persistent burners. Return to play guidelines for acute first-time stingers. The athlete may return to the same game competition if symptoms have completely resolved. Contraindications to play following an acute stinger include any of the red flags, incomplete range of motion, neck pain, and/or residual symptoms. If symptoms are not resolved between 4 to 10 days, further investigation is needed. Recurrent stingers. An athlete who has incurred fewer than 3 prior burners with symptoms lasting no longer than 24 hours can return to the game the same day. If the symptoms do not resolve, athletes should be barred from further play and further imaging is needed to investigate underlying pathologies. Contraindications would be 3 or more prior burners or symptoms lasting longer than 24 hours. Here is a summary of contraindications to play from Vaccaro et al. Controversies surrounding return-to-play guidelines with recurrent severe stingers. An EMG can be abnormal in up to 80% of athletes even after a 5-year follow-up. Normal EMG results have been found even though there was still prolonged weakness following a burner. Therefore, physical examination should be favored due to the variability in EMG results, and athletes can return to play as long as they have normal cervical spine range of motion and full muscular strength. Torg ratio is the ratio between the diameter of the cervical canal to the width of the cervical body. Cervical stenosis is present if the Torg ratio is less than 0.8. Players with a Torg ratio of less than 0.8 had 3 times greater the risk of incurring a stinger. However, 1/3 of professional and amateur football players have a Torg ratio of less than 0.8 and continue playing. Also, cervical stenosis may be only one factor of many that may predispose an athlete to stingers. Therefore, a Torg ratio of less than 0.8 should not absolutely contradict an athlete from play, but physical examination and further imaging should influence return to play timeline. To summarize, return to play requires clearance by the treating physician or athletic therapist, full range of motion of the cervical spine, be asymptomatic with and without testing, have a negative neurological examination, negative Sperling's and Tinel's tests, full strength in the neck and upper limbs. Emphasis is placed on physical evaluation due to the inconsistencies of diagnostic testing. There is a lack of standardized return to play criteria for burners, and guidelines are recommended based on the best evidence to date. Now, for a participation activity, please read the following scenario and answer the questions.
Since stingers and burners are really commonly ignored in sports, we want to show you how detrimental the effects on their play it can be. So we're going to do an activity where you're going to hold one arm at your side and you're going to toss a ball with a partner back and forth, and you can show how detrimental this actually can be on your throwing capability.
Please get into partners and discuss the following questions. To summarize, stingers and burners are a common injury, classified as a brachial or nerve root injury that causes tingling or numbness in your arm. They are very underreported and have a high occurrence in contact sports. There are 3 common mechanisms of injury for a stinger. On-field protocols help rule out more serious injuries, and return to play guidelines based on the absence of symptoms and return of full function to the neuromuscular system. The student should now be able to answer all of the following learning objectives.